Welcome to Behind the Sports Medicine Podcast, the podcast that pulls back the curtain on the evolving world of sports science. I'm Andrew Rizza, an athlete trainer with decades of experience in professional, collegiate, and high school sports.
And I'm Cameron Roth, an orthopedic surgeon and a consultant for the Chicago White Sox.
In each episode, we'll explore the real-world challenges and opportunities facing today's human performance professionals.
Our hands-on experience is transforming sports medicine and breaking barriers through innovation and teamwork.
Hey, everybody. Welcome to this week's Behind the Sports Medicine Podcast. This week, I have Dr. Meghan Garcia-Webb, who is an internal medicine physician and also a weight medicine concierge physician. Dr. Garcia-Webb earned her Bachelor of Science degree at Tufts University and her MD from the University of Vermont Medical School. She completed a residency in internal medicine at University of Massachusetts and has been on staff as an internist at Mass General Brigham, Newton Wellesley Hospital, and Bethersfield Deaconess Healthcare. In addition to her clinical work, she produces a weekly YouTube series, Weight Medicine with Dr. Meghan. Dr. Garcia-Webb, welcome. Thank you for coming on today and wanting to talk about weight medicine and life coaching.
Thank you so much for having me. I'm so excited to be here.
And our co-host, Dr. Roth, is here as well, who's hopefully going to have a lot more educational questions for you than I will.
No, of course. We were just talking earlier. Super excited to have you. We're going to learn so much. It's such a huge issue in the past few years, especially with the medical treatment of weight loss. And obviously, you've been touching a lot of lives, making a lot of people healthier and their lives better. So we appreciate you coming on.
Thank you so much.
Can you give us a little bit background on how you got into the concierge weight management and lifestyle practice and where that is today?
Absolutely. So I started out in primary care, and it becomes very apparent that when you are doing primary care, you are doing obesity medicine and weight medicine by default, because that is usually most of what is driving a lot of problems for people in terms of high blood pressure and diabetes and joint issues and so many problems. So from there, I did my boards in lifestyle medicine and obesity medicine. And then I still felt like there was something missing in terms of helping people make those changes. I feel like in medicine, we give patients a lot of information and we say, hey, come back and see me in a month. Hope that goes well for you. And we try to educate as best as we can, but we're also pretty limited in terms of the time that we have to spend with patients in a traditional insurance-based model. So that led me to get certified as a life coach. And I really felt like that was kind of the secret sauce in terms of helping people go from where they are to where they want to be. Mm-hmm. And so I opened my own practice so I could really do everything for people. So for people in Massachusetts, I can do all the medicine and all the life coaching. And then for people around the world, I can do the life coaching on its own, which I would say is about 90% of people's issues with their weight anyway.
So I don't want to jump ahead here, but you said you took your boards in obesity medicine. Mm-hmm. Can you just give us a quick summary about that? I just remember in medical school, we talk about nutrition for about 10 minutes and then you just learned that obesity is a risk factor for everything bad. So what things did you have to prepare for your boards, for obesity boards? And then what did you realize, I passed my obesity boards, but really there's so much more information that I should know?
Yeah, so it probably took me about 6 months to prepare to pass the boards. And it's a lot of, you learn, in addition to the obesity medicines, you're learning about bariatric surgery, how to care for patients post-bariatric surgery. And you're also learning about genetic causes of obesity, which are rare, but, certainly pop up every once in a while. And then you learn, I'm internal medicine, so I didn't learn, I'm not a pediatrician, but you do learn about pediatric care of obesity patients too, which I think is helpful because a lot of parents have questions if their children have obesity or things like that. So it's a pretty comprehensive exam. I think the important thing for me to understand is, this is such an early stage of this field of medicine. And so you take the boards, but, in 2 years, it's going to be very different in terms of at least the medications that are available and how to treat people. So it's rapidly evolving, and it's certainly one of those branches that you have to keep up with the literature.
Who is seeking help? So do you have any statistics off the top of your head? I mean, I know people throw around, a third of the U.S. has, type 2 diabetes or is obese based on the BMI scale. Who is coming to your clinic? What's your daily clinic like?
So my clinic, I do 2/3 of my weekly clinic is weight patients. And yeah, in terms of US population, about 73% of the population is either overweight or obese, and over 40% is obese. So, and that's a BMI of 40 or above. So about half of the US population would qualify for weight medication, which is pretty staggering from a health perspective, also, a financial perspective. If you think about the cost of these medications and that half the population would qualify for them and what that would mean for the insurance companies, it's pretty drastic. So for me, I see, 2/3 of my clinic is weight patients, and a lot of it is follow-up. So I feel really happy that I can really provide oversight for people in terms of these medications. I mean, when I'm working at the BI, I do pretty much only weight medications. There's not as much time for the education aspect of it. But I think a lot of people are getting these medications from different, online purveyors, and it's very easy to get, and there's very little oversight, and they'll come see me and they'll be like, I feel like this is unsafe. Like I got a text message that it was approved, and then they sent it to my pharmacy, and then it showed up, and if they're taking compounded medications, a lot of times they don't even know how much they're taking. So it's very difficult for me to convert it. So we kind of have to, start from zero for some people. But yeah, so a lot of it is oversight. And then that's for the BI practice. And then for my private practice, I really try, it's always my goal that we are doing the most with the lifestyle changes first. And so that's my favorite thing when I can, like I just had a patient who she lost 20 pounds on her own. She didn't think she was going to be able to do it, but she did. And now she's like, oh, thank you so much for pushing me through this, because I really thought I was going to need one of those medications. And now she doesn't. And she feels better, but she's really happy that she avoided that as well.
Now, do you have patients that will show up and that's all they want is the medication because they've tried other types of weight management strategies and they haven't worked? And then you have discussions on maybe let's look at this and go down the road of maybe looking at what your behaviors are and maybe start there first. How's that discussion start when they come in to see you if someone's just looking for the meds versus changing a behavior?
Yeah, that happens a lot. Definitely in my hospital-based practice. Certainly people come in, they're like, my sister's on this, she's lost so much weight, or they know a lot of people who've been on it, or they've heard a lot about it. And they're like, I really want to start something. And so I'll just go through and get a general idea of what's going on with somebody, because sometimes there's a lot of wiggle room in terms of what people can try on their own. And especially if people, are kind of borderline in between, like they have a BMI of 27, there's a lot of eating issues that they could probably tweak and get some good results from, then I might persuade them to go that route. But I also have patients who they're just exhausted by trying so many things. They've tried so many different diets over the years. They've had yo-yo dieting, or they're on medications, and I can clearly see like they can try everything they want, but it's probably not going to result in the type of weight loss that they would achieve if they weren't on these medications. So it's very individualized, but I don't really have a problem starting a medication when I first see somebody, if it's the right thing, if I feel like it's the right thing for that person.
I'm going to put you on the spot here, and I want a very straightforward answer that everyone is looking for. But what causes obesity, and what are some misconceptions about obesity that people come into your clinic and ask about? And I know there's probably no straight answer for that.
Answer.
Right.
Thank you, Dr. Roth, for that. That's great.
That's a great question. It's certainly heterogeneous, the causes, of course. Of course, there's genetic issues. Of course, I see a lot of medication-related obesity. I see a lot of women who have been put on an SSRI after they had kids, or an SSRI in the perimenopausal time period, which could be very helpful for them. But also then they come to see me 2 years later and they're like, what, where's this 20 pounds come from? Like, I'm doing all the things. I'm like, well, and we can look back and it's pretty clear that it's like, well, it's when you started the Paxil. So I think that's very helpful for people to understand that there are these other factors that are playing it. But if I had to give it one answer, I would say like the US culture causes obesity. Like it's really, if you do the default in America, you will be unhealthy. Like our whole culture is built around people being productive, eating through work, grabbing convenience food, eating in the car. You know, there's so many preservatives, there's sugar in everything. So I think it's really hard for people to be healthy. We make it very obstructive in a way that if you grew up in Italy, like it's not that hard to eat fresh food. And there's also these rules that really protect people. Like this is when we eat. We don't eat at our desk. You know, I had a patient who was, you know, working at his like company office in Switzerland, and he works here, but he works for a pharma company and went to Switzerland to their office, and he ate on his desk, and they almost kicked him out of the office. They were like, "What are you doing?" Right? And here it's just, well, of course you eat at your desk. Like that's the most important thing, that you're like multitasking.
Yeah.
So I think it's our culture that makes people obese. You had a second question. What was the second question?
Oh, misconceptions. So what are people attributing their obesity to that you may have a different opinion, or that you may pinpoint different pathology?
I think a lot of people feel like their body is like against them, or there's something wrong with them. And I think the big misunderstanding is that there's like one magic thing or one supplement that people can take or one workout that they can do. Just in terms of lifestyle things, I think it's really about being consistent with the boring things. And it's like, how much fruit are you eating? How many vegetables are you like? Nobody's eating produce. Nobody is stopping when they're full. Nobody knows when they're full. Like people just eat based on the size of their plate.
Mm-hmm.
And I always try to get people back to that kind of childhood way of eating where, you know, if you've ever seen a 3-year-old eat, they just like, they'll leave half a plate of cake and then just go run around and play because they're done. Right. So they're hearing the messages. But I think a lot of people think like there's something wrong with them, or that there's a magic tool. And there kind of is a magic tool now with the medication. Like it is very helpful, but it's like, no, you just haven't been doing the things that, you know, you probably don't even hear because they're so basic, but nobody actually does them.
That makes sense. I'm sure a lot of people come into your clinic and say, hey, I just saw this TikTok video that says if I eat steak and egg yolks every day, I'm going to be very slim. And then you ask them how much produce
Their
they eat.
cholesterol level. Yeah.
Yeah, I mean, but TikTok rules all. So
TikTok does rule all.
Yeah, so I'm sure you get a lot of that, what I would like to call misinformation.
Yeah, a lot of people yeah, I do get a lot of that. Or we just don't really have any good nutrition education. Like people will tell me something they think is very healthy. And I'm like, I didn't see any fruits and vegetables in what you just told me. Or like that bar that you just ate, like has a lot of chemicals. Like you could just eat a banana, you know, like that's going to work better for what you want. I think people have so much faith in like these sciencey products. And I just think like, we don't do a better job than nature. Like, and that's not how we evolved to eat sciencey products. Like our bodies are the same as they were like thousands of years ago. So whatever we're making is not going to be as good as what we have naturally evolved to eat.
Well, you're probably fighting a losing battle as a nutrition and weight loss specialist, because the marketing behind all those sciencey products is so much more than you can do as a sole practitioner, even with all your knowledge.
Yeah, I think like people have no idea like the market forces that are designed to keep them eat, like the people who are employed to make foods addictive, you know, or like so delicious, right? That how much that's studied, how much it's marketed, you know, how much it comes through their phone. Yeah, so I think it's possible, but it does, if you do the default, you're just going to wind up eating things that are not very healthy for you.
Yeah, I mean, I was talking to a patient, had been several months ago, about when I was growing up. I remember my grandmother would tell me to go down to the grocery store for her if I was visiting. Like every day, she would send someone down to the grocery store to get fresh food, and she would make food it was fresh. It wasn't frozen. It was, if she's getting beef or chicken or fish and the vegetables, like that was every day. And they had a garden where they had vegetables they grew.
Right.
And, she was from Italy, or my grandfather's from Italy. She was born here, but she was also Italian. But that was their culture, compared to today, where, like you said, it's on the run, it's quick. We're sitting down eating, we don't take time out. You have too many things going on at once, and that becomes a problem where I think the culture is definitely the issue compared to where we are. If we go overseas to visit someone in Spain or Italy or, Greece, it's sit down at lunch for 2 hours and enjoy your food, and then, you go about your day. So it's definitely different.
Right, exactly. And how nice for you to kind of witness that growing up
Mm-hmm.
in a way that a lot of people don't see that, right? They don't see their grandparents gardening, or like this is something you could do, or what like fresh fruit and vegetables taste like.
Do you think some of it is also preparation on the person's part, where they, for them to prep meals for the whole week, like it takes time if they're working a lot, or they're becoming that time crunch for them working as a professional with kids, with all the stuff going on today. And it's just so easy to get that quick meal that they can just heat up.
Yeah, I think a lot of it, like people are just so used to right now, like surviving, especially like working parents. It's like, what do I need to do to like get through the day and get food on the table and like get people to bed? And I think it's really overwhelming for a lot of people. And that's a big barrier to change. And so when you do have these convenience products, it's like, okay, well, at least we kept it going for another day or two, right?
Mm-hmm.
Whereas to really stop and think, okay, I need to make a change. I mean, that's hard for people. And I think there's a lot of mental resistance to that. But I also think, my goal is always to make things really easy for people. I don't think it has to be overwhelming. I don't think it has to be hard, but it does take some upfront investment of time and attention. But my goal is always to like create something for somebody that's so automatic and simple that it, is eventually kind of runs on default. Like they have a default now, and the default might be like, well, we order takeout a lot more than we want to. And, we have a lot of convenience foods that we rely on, or we buy these things in bulk, right? So you have a default, but I think it doesn't have to be as hard as people think it is. And especially with like Chat GPT now, there's some amazing things you can do with like meal planning or meal prep, or how many grams of protein you want in your meal. Like it's really so helpful for people.
That definitely speaks to you as a lifestyle coach, which I think reframing people's perspective around food preparation, family time, and what it means to come together for a meal and enjoy the meal, like Riz was talking about. And you're absolutely right. People are just trying to, quote, get through the day, or just trying to survive another day. I don't have children, so it's hard for me to completely empathize with what it's like to have small children running around and have a full-time job. I totally understand that's difficult, but making a space in your day for appropriate, mindful food consumption, food preparation in the most healthful way, I'm sure that's a big part of your life coaching.
Yeah, I really like to tell people it's win-win. Like a lot of people think they have to give up something or it's going to be harder. But what I really want to tell people is like, this can be better, like much better. You can have a lot more peace around how you're eating, and you can eat better, and you won't hate your life. So yeah, that's always the goal. But it's hard because people are very tied between these two poles of like, it's very all or nothing. It's like, oh, we're eating terribly, all this takeout and processed foods, or there's this diet culture and like, how many macros did you get? And, it's very sciencey. And I think there is truly another way, which is somewhere in the middle and probably more aligned with how, the Italian grandparents grew up.
And you mentioned earlier, like people can just go online and buy things, right? And they come in and like, oh, I bought this medication. It doesn't feel like it's helping me, or I don't know if it's the right thing for me. I'm taking this much dosage. For you as a physician, and you're prescribing these medications, what's available? And then kind of what's, I guess, maybe the second part of the question is, over the counter versus prescription.
Great question. So right now there are 3 FDA-approved injectable medications for weight loss.
Mm-hmm.
So the first one was, and it's confusing for people because the medications have 3 different names. There's the generic name, the name of the drug itself. Then there's the name under which it was approved for diabetes. And then there's the name under which it was approved for weight. So the first one was liraglutide, and that's a daily medication. And that's a GLP-1, and it's Victoza for diabetes and Saxenda for weight. Then there's semaglutide, which is a weekly injection, and it's Ozempic for diabetes and Wegovy for weight. And then there's tirzepatide, which is a GLP-1 and GIP receptor agonist, and that's Mounjaro for diabetes and Zepbound for weight. Generic, or if not generic, you can kind of make your own sort of version with it, what's available generically. So there's phentermine, there's bupropion, naltrexone, and there's Qsymia, which is a blend of phentermine and topiramate. And then there's, things like metformin, which are not approved but are generic, and you can use them off label. And those don't work quite as well, but can be used to augment somebody's weight loss if you're not quite getting the result that you want with the injectables. And then there's certainly, you can get compounded versions of these. So, theoretically through a physician or some sort of clinician, and you're not getting the exact same thing. So, and the compounding is very controversial. And I have, lots of people who tell me on my YouTube channel, they're like, I love my compounding pharmacy. It's amazing. I'm like, okay, but like, you don't really know what you're getting. Right.
Yeah.
So is it going to be fine sometimes? Like, probably, but that's really not how I like to practice medicine. Is like what I give you is like, I think it's probably going to be sterile. That's not how I love to do things. But, and then, there's all the horror stories that I'm sure there will be more of people, not getting what they think they're getting, or it's diluted, or things are added to it. And yeah, so those are available too. Probably less so now that the shortages are not quite as pronounced, but still an issue.
Can you explain how they work? Because I think people think that they inject or take something, it just melts fat away. I think that's the perception.
Yeah.
Can you just explain on how the medications work for the patient and what the expectation might be for them if they are prescribed them?
Yes. So the GLP-1 medications work really well because they work in a couple different ways. So one of the ways that they work is they really slow the movement of food through the stomach. So they strengthen that message of fullness from the stomach to the brain. And then they also work in the brain, in the hypothalamus, we think, to really affect the balance of fat storage and fat burning. So it just makes it a lot easier for people to lose weight. And that's why if you stop taking the medication, that adjustment goes away. And so that's why people are they can do all the same things. But if you take that away, the weight's going to come back on. And then for some people, not everybody, but for a lot of people, it also seems to work on the reward circuitry and how people view food as entertainment and kind of like a more intense kind of pleasure mechanism. It seems to really turn down the volume on that as well. But it doesn't melt away fat.
That would be too easy.
That'd be too easy.
What is the typical effectiveness? I guess we're focusing on GLP-1 agonist. What is the typical effectiveness? What amount or what percentage of weight loss is typical? What's an appropriate timeline for the patients? And then what is the most recent literature saying about how effective these are, how long do they last, and what the safety profile is?
So the GLP-1 medications are certainly the most effective at weight loss. And, something like liraglutide, people can expect to lose about 10 to 12% of their total body weight. But then there was a real jump with semaglutide and then tirzepatide. So for semaglutide, the average weight loss is about 15%. And then with tirzepatide, it's more along the lines of 20%. And which is, we're approaching now what people can achieve with bariatrics. So, which is incredible for people. In terms of the lasting effects, we have some good data, especially with tirzepatide, that when people stay on it for a more extended period of time, and we don't have a lot of research on this because especially with tirzepatide, it's the newest one, but we can see that people tend to lose even a little bit more weight over time. A lot of people are worried that, if I'm on this, it's going to stop working or that the effects are going to wear off. And so far, that's not really what the literature has shown. If anything, people may be losing even a little bit more. And then in terms of safety data, there are a small percentage of people that are going to discontinue. And the reasons that they usually discontinue are due to the GI side effects. In terms of how long to give it, that's, kind of the blanket rule is, around 5% at 3 months as you're titrating up. But I always think that's very patient dependent as well, because especially if somebody has a lot of medication issues or they have something like diabetes, there's some conditions that are just going to be, you're not always going to get the optimal effect. I will really give it until the top end of the dose to see if they're going to get that effect or not, because some people just don't really lose until the very end, especially if they're on like gabapentin or Lyrica or things like that.
Are these medications meant to be short term? You lose your weight, you wean from the medication, and suddenly everything's better? Are they meant to be maintenance medications? And then do you see people who wean themselves off the medications and then have a weight gain back if maybe we haven't addressed some of the underlying issues?
Yeah, that's probably the other big misconception is that people think like, oh, I can go off this later, right? And it's no, like these are lifelong medications. And I also tell people, this is going to look very different in 5 to 10 years. Who knows what we have? But for right now, everybody who's starting these should really go into this with the idea of, I'm going to be on this forever. I'm okay with that. I'm okay with the annoyances that come with getting it approved or the shortages or things like that, because that's a whole nother separate headache for people. But it is a lifelong medication. And then probably it's about 15% of people. So we have the latest data we have is from the SURMOUNT-4 study, which was tirzepatide, where they did a double-blinded study. They titrated people up on it, then they switched some to placebo and some they kept on the high dose tirzepatide for about a year. And the people who were on the placebo, even though they were doing all the same things, they did gradually gain back the weight. About 15% of the people were able to keep the weight off. So there is this very small percentage of people in the limited data that we have that probably can. But to me, that's never something I would encourage for people, because most people aren't going to have that kind of effect.
Does lifestyle still matter then, if this is a lifelong medication?
Yes, lifestyle definitely matters because, I always tell people, like, you want to get your money's worth out of this medication. Like, it took a long time to get approved, or maybe you're paying cash for it and it's hard to get sometimes. And you really want to make sure that you're doing the most to help it work. And so I think the lifestyle changes really help with that. And I do have patients that they just take it, they don't change anything else, and they lose weight, but they probably would be losing a lot more weight. Or I have patients who they made the lifestyle changes and then they kind of taper off those. And then they come in to see me and they're like, oh, I gained 5 pounds. And I'm like, yeah, because you stopped the other things. So the medications are one thing, but they don't do everything. And then especially for people in terms of muscle strength, that's really important too, because every time we lose weight, a small percentage of that is muscle. And it's really important to keep, preserve or even build that muscle, because it's the few ways that we have to help our resting metabolic rate. So that's a really important part of it as well, is just making sure that, people are committed to doing that. Especially patients who are, I have patients in their 60s and 70s, and, the last thing you want is to contribute to frailty or something like that.
Do you do serial blood work with hemoglobin A1C, coronary artery calcium score, body fat percentage, visceral body fats, vitamin D levels? And then what have you seen with patients who adjust their lifestyle in conjunction with the medication versus those who just go on the medication?
Yeah, I do. I check labs probably about twice a year. And then for patients in my private practice, I always love doing a DEXA before they start and then after. So, and it also gives you different targets to look at. And of course, the people who are doing more with their lifestyle are going to see improvements in their percent body fat and their lean muscle mass. It's a little hard with the blood work, especially with the A1C. The injectable medications do such a good job lowering it that it's, they're pretty powerful from that extent. So it's hard to tell, if the lifestyle changes are having an effect. But, certainly when I see patients who are just doing the lifestyle changes, they can make a pretty profound effect on their hemoglobin A1C. And there's also a lot to be said for, genetic profiles as well, because if someone has a family history of diabetes, they can be doing all the right things, and that's going to be a little bit harder to move the needle on.
Cam, did you have a follow-up?
I have so many questions, but I've been talking the whole time.
That's why I have you on here. You sound so much better than I do. Can you talk a little bit about safety and efficacy? And I think really the question or the answer I think people probably want to know is side effects of the drugs, the effectiveness of the drug, right? How that works. And then any tolerability and long-term safety data that might be out there now with some of the newest research.
Yeah, I would say, in the research, the safety and efficacy is it looks quite, at least the reasons that people discontinue, the percentages are quite low. And I would say, in my experience, that is also true, but I think it's also because I'm able to work with people because I'm following them. And so I'm seeing them pretty regularly. And so if they say, I have this nausea that came up, or, other GI issues that are really interfering with their quality of life, we can address that pretty early on and either make a lot of people just don't understand that you can't eat as much. You need to kind of back off the heavy foods. Like, there's a lot of things you can do with what you're eating. And then there's also a lot of, medications that you can use to help the side effects. So I rarely have people discontinue medication. Sometimes I'll switch them. So sometimes people will have a better response between semaglutide or tirzepatide or vice versa. And liraglutide seems to have the most side effects anyway. But I rarely have I could probably count on one hand the number of times somebody's just said, I'm not doing this. I hate this. I want off this ride. So most of the time there's a way around it. And then oftentimes these side effects get better with time as well. So sometimes it's just a matter of not escalating somebody very quickly, keeping them on a low dose and just going up very slowly. And, somebody's not going to care in 5 years if it took them 12 months or 18 months to get to the top dose. They'll care if it's working and they can tolerate it. So I think that's the benefit of working with somebody closely, is that you can really make those changes. And that's, I think, a lot of what I would suspect if people are getting them from, online sources that don't have a lot of oversight. It wouldn't surprise me if more of those people are discontinuing them because they're like, this is terrible. And they don't have a lot of help in terms of adjusting with those side effects.
What are the most typical side effects that you see? You mentioned nausea as one. What's kind of the list of things that you'll typically see with some of these medications? And I'm sure it changes medication to medication, but
right.
If we're talking just the like Wegovy, like the typical GLP-1s? Like, what are some of those things that you'll see with patients?
Yeah. So I tell people, like, get ready for annoying but manageable side effects. So it's some nausea, maybe some vomiting, diarrhea, constipation. Those are the big ones. And then fatigue comes up for people quite a lot. And so those can be very limited in terms of they just happen in the beginning. And then they go away with time, or every time somebody escalates the dose and goes up, they can kind of flare up and then go away. And then for some people, they just never go away. And so, but most people, we can find a way to manage them. Every once in a while, I have somebody who has no side effects, and they're like, yeah, my appetite decreased and I'm losing all this weight. So there are definitely those people. And then there are the people who, that first dose, they're like, I have food poisoning. And they just, those are the people who have a harder time sticking with it, of course. There's always, all these things on the news, like stomach paralysis and like small bowel obstructions. And those can definitely happen. I think they're a lot less likely to happen if somebody's checking in with their doctor, because you want to stop that before it happens. And they're also, my experience, pretty rare. And then, every once in a while, somebody has a lot of gallstones and that, needs their gallbladder out, but that can happen with any sort of more rapid weight loss. So there are some extreme rare side effects, but I tell people that's for any medication. And also there are side effects if you don't treat this. So you have to think about that as well.
You mentioned the use of GLP-1 agonists and its effect on the dopamine reward system. So as we know, the dopamine-rich areas in your brain, they govern reward, motivation, reinforcement. So that's big for food addiction, drug addiction, etc. What do you know about the use of these drugs in addiction medicine?
I think they're going to have a really important place in addiction medicine, from what I can see clinically. And certainly it's nothing that has been approved yet. But I could definitely see a world where, people are on a low dose of these medications and it really helps with alcohol. Binge eating is another issue that is really helped. There's not a lot of medications for binge eating. Vyvanse is incredibly helpful, but not everybody can take Vyvanse. It's a stimulant and not a great fit for everybody. And you can combine it with something like tirzepatide or semaglutide. So I think it's a really helpful medication for that. So yeah, I could definitely see a world where it's kind of like naltrexone in helping people with cravings for whatever addictive behavior that they're having. Yeah, I think it's definitely has a lot of potential. And I have so many patients that just say, I just don't even think about alcohol anymore, which is incredible.
It would be incredible if I have a overweight patient who's a smoker who needs a shoulder replacement, and we can refer them to you and you can put them on a GLP-1 agonist, and suddenly they quit smoking, they lose weight, and they're the optimal candidate for shoulder replacement. That would be unbelievable, because not only would that change them physically from multiple aspects, so just giving them the use of their arm back and decreasing their pain, but quitting smoking, which arguably might be the most important out of all those three, losing weight and completely getting their life back. I mean, there is so much room for success here, with conjunction with experts like you and then people in Rizza's field and my field. We can really make a difference in people's lives with these medications. That's unbelievable.
Yeah. I mean, I think the more we learn about them, the more they seem to help so many other things, cardiovascular health, liver health, behavioral health. Who knows what we'll see in the future, but I definitely, in terms of addiction, I think it'll have a place there.
Yeah, I mean, I think Cam, you made a great point there about the shoulder replacement, because we see so many, not a lot, but we see patients that have, they're smokers, that heavy alcohol use, that have repairs done, surgical repairs and their tissue quality isn't great, their bone health isn't great, so their outcome is going to be worse,
Right.
or less achievable than we'd like to see. So I think if that was the precursor to the surgical procedure, is to try to get their lifestyle the way that it probably should be for the longevity of their life, but also for a better outcome for their surgery, would be amazing.
Yeah, I really feel like it's this tool that we have that, there's so many forces working that are making, not helping people to live healthy lives. And this is really one tool that we have that can push back against it pretty strongly. And it can't do everything, but at least it's one thing that we have now.
I want to play devil's advocate here. So you talk about all these forces that are pushing us into the corner of an unhealthy life. And then we as humans seem, maybe we as Americans at least, seem somewhat powerless to battle these forces. Now we're just inventing medications to deal with all our issues. What is there to be said about willpower, mental health, lifestyle changes, doing all of this or the majority of this on your own without just chemically modifying your neural pathways and digestive pathways and improving your life without the help of pharmaceuticals and multiple medical experts?
Yeah. I mean, it's always my goal. Anybody who's starting these medications, it's in an ideal world. They've maxed out all the lifestyle interventions and they're doing, they're eating how they want to eat and they're exercising how they want to eat or how they want to exercise. And I think the people who get to that place, because certainly I do have patients that they do all that and then their weight really hasn't changed or is still higher than we want it to be for them. And whether that's more of a genetic issue, maybe they have diabetes, maybe they are on medications that are really fighting the weight loss. There's a lot of reasons for that. But I definitely have patients like that. And I think those are the people who are most comfortable with their decision to take these medications because they're like, well, I'm doing everything that I can do. And it's clearly only getting me to this part. And so, they feel comfortable with that decision. But yeah, I do, there certainly is something to be said for, is 50% of the population going to be on this? And what does that do in terms of are we missing something in terms of making those changes on our own? And, of course, I want everybody to change their lifestyle and really focus on that. I also think that our culture makes it hard to do. Not that we shouldn't, but recognizing that not internalizing that as a personal failure, but recognizing that it's probably going to be a little bit more of an uphill battle for somebody here than if they're living somewhere else. And also sometimes I think, I do want everybody to change their lifestyle, but also, we're kind of burning daylight in terms of people's health and a lot of people are on the closer end to having a heart attack or getting diabetes, or at least we can just get people to a safer place in terms of preventing these things from happening. But I do think, it certainly is a concern. I also think about for parents who are on these, what, are we helping children to eat differently, or are we just changing how we eat, but the kids aren't getting the healthy foods? That's something that is more of a pediatrician wheelhouse. But I wonder how much of these changes are being passed down versus just kind of perpetuating the unhealthy status quo.
We live in a quick fix society, right?
Mm-hmm.
So our legions of listeners are going to be looking for some takeaways from this discussion. So what are Dr. Garcia-Webb's expert nutrition tips? And
Don't watch TikTok.
Don't watch TikTok.
We'll take it.
I think before you answer this, I have a comment. I think our biggest thing, you mentioned lifestyle in the US. I think social media is the biggest deterrent from good lifestyle. I feel like everybody's watching TikTok and Instagram and, hey, you can take this, you can take that, do this workout, do that workout, instead of, there is some more healthy choices to look at, like for food prep, which is really good. But I feel like everybody, like you said, is looking for the quick fix, right? But that, my opinion is, like, if we got rid of the social media, which we all use for work related stuff, is good. But I think for lifestyle stuff, it can be pretty harmful, especially for the young kids, because they, without their phone, I think they couldn't figure out how to get out of their house. So,
Oh, yeah.
I agree, but I think everyone knows now that social media is bad for you, but people keep using it.
yeah.
So when I go on, I don't have social media, but when I go on Instagram and I see Dr. Garcia-Webb's page, obviously well-trained expert in weight loss therapies, weight loss medicine, nutrition, lifestyle, etc. How do I differentiate between you and all your legitimate, good information, altruistic, trying to help information, versus the guy with the 8-pack who eats steak and liver pills and runs barefoot? So, what's some advice where we can find actually legitimate, good information from experts like yourself?
Yeah, I mean, I would definitely say, like, consider the source. If it seems too good to be true, it probably is. And a lot of these things that we, know, like, a lot of people just don't, it's hard to hear like the things that we know we need to be doing. So yeah, I would certainly, like, if you're following somebody, like, what are their credentials? Is this some, random person who thinks you should take all these supplements and there's some sort of like financial, incentive for that? Or is this somebody this is their job, they're a healthcare professional, they're not marketing things like, supplements or things to you. And it's really just for information and education purposes. Yeah, there really isn't a quick fix. I would say, like, in terms of my advice for people, it would really be like, just embrace the boring. Like, it's always good to be, I tell patients, like, you want to be so medically boring. Like, and which is also countercultural because we want like all the stimulation, but you want you want your routine to be so, not dramatic, not chaotic, just very easy. You want how you eat to be very rote. And a lot of the things that we need to do are boring. Like, I always tell people, like, one of my like top 3 takeaways, one of them would be like, just eat and don't do anything else while you're eating. Like, don't be on your phone.
Mm-hmm.
Don't watch TV. Like, and I tell people, even on these medications, if you're eating and you're distracted, there's a window where your stomach's telling your brain, like, we're good. And if you're just scrolling, you're going to miss that early signal. So that's one of them, is just, and it sounds like very boring and it's so hard for people to do. Like, people are like, yeah, yeah, yeah. And I'm like, did you try it? And they're like, yeah, it was hard. Because they're so used to doing other things. We're so used to being, like, with social media, we're so used to being entertained all the time. So that would be one of them. And another one, also not exciting, is, 5 servings of fruits and vegetables a day. If you do that, there's just less room for other things. And I like that because I think when people are making nutritional changes, they get into this mindset of like, what am I going to have to give up? Like, this is going to be terrible. It's like, no, let's think about what you can have more of that you like. And then making those, half your plate. And if people actually did that, it would make a very big difference. But people are always like, yeah, but what about this supplement? And it's like, okay, the supplement is not going to do what you think it's going to do. But yeah, people want the quick fix. But the changes that they need to make are actually not that hard in terms of complexity. It's hard in terms of like attention and navigating the kind of boredom, and that they're not exciting.
Do you know about the philosophy of, I might butcher this because my Japanese is rusty, but the hara hachi bu, eat until you're 80% full philosophy that they practice on Okinawa, which is one of the blue zones?
Yes. Yeah. That's exactly like nobody knows when they're full in America. They're just eating. Because I ask people every time I meet with somebody, I ask them, like, what did you eat yesterday? And I also ask them what they're doing while they're eating. And most people are not stopping because they're full. They're stopping because they cleaned the plate. So, yeah, I think if people did that again, but it requires listening to your body. And that requires not being distracted. So all of this is very easy to do, but it's very countercultural.
Yeah,
Well,
we
you
can
can't-
blame it. We can blame it on our parents because of, like, you can't get up off the dinner table until you finish all the food on your plate.
Right. All that kind of depression era mentality that
Exactly.
got trickled down
Yeah,
is
and the
not
Italian,
actually
and our Italian heritage was like, eat more, eat more, eat more. You know,
right. Like, there might be a famine. Eat more.
Yeah, exactly.
Yeah.
Well, now our food is more hyper palatable than ever.
Right.
So the three V's of addictive food: variety, velocity, and value. You can just shovel food in your mouth that tastes better than anything you've ever tasted in your whole mouth or your life, and
Right.
scrolling through your phone. So you're getting all the circuits hit at the same time,
Right.
and suddenly you eat till you're 110% full and you feel terrible, and then
You got to go lay down.
Yeah, exactly.
Right. And it's like, do you want, like, I don't know, do you want to keep living like that? Right. Like, to me, that seems pretty unpleasant. I think if people really lean into how unpleasant it is to be overly full and they're not distracted, like, that is a natural negative feedback loop. Like, if people really sit with, like, I feel terrible, then that really helps kind of negatively reinforce that behavior. But again, it's most people, when they feel terrible, they are trying to distract themselves from that.
What's balancing the joy of eating a whole can of Pringles in 5 minutes versus feeling terrible afterwards? What you really remember is the saltiness and the crunchiness of the Pringles as you put 3 or 4 in your mouth at a time. And then you just accept feeling terrible, and you think having that post-lunch food coma is normal. And then you drink an afternoon coffee to re-stimulate yourself, and then sort of you're in this vicious cycle again. I think you're 100% right, being thoughtful and mindful about how terrible you feel after.
Yeah. And I always like to ask people, like, how much time or how much time did that buy you? Like, in terms of the pleasure, right? And most people are like, a couple minutes, right? It's like a couple minutes of feeling amazing because you're eating the Pringles. And then it's hours or days, you know, or, a lifetime of feeling awful because you're dealing with the repercussions.
Yeah, 100%. If somebody wants to get in touch with you to discuss kind of their behaviors, either as a life coach or come to see you as you're being their physician, and working with them on the concierge side of the weight management, what's the best way for them to get in touch with you?
Yeah, the best way to get in touch with me is through my website. It's www.weightmediциnemd.com. And I have a little link there where they can sign up for a consult. It's completely free. We'll just talk about what's going on with them and see if it's a good fit and go from there.
Do you have peers or colleagues that are around the country that needed somebody to see in person? Like, say, someone that Dr. Roth had in Arizona. Is there anybody that you have that you could refer if you got them as a consult from listening to this, and they said, hey, I really want to see somebody in person and I'm in Arizona? Do you have that network that you can actually steer people to?
Yeah, so I always refer people to the website of the American Board of Obesity Medicine, because if you go on that, there's a directory state by state, and you'll get a whole list of doctors who are obesity medicine certified. And so that's the first place I would start.
That's great.
We've hit on a wide variety of topics. This has been so educational for me, and I'm sure for Riz, and of course, everyone who's listening. We really appreciate your expertise, your time, your advice, you're really going to make a huge difference in a lot of people's lives. So thanks. We really appreciate it.
Yeah. Thank you very much. We appreciate you taking the time today.
Thank you so much. I really loved being here and I love talking about this. And it was just lovely to talk with you both.
Thank you, Dr. Garcia-Webb. We will talk to you soon.
Thanks for listening to Behind the Sports Medicine Podcast. Follow us on social media and check out our website.
The information shared on this podcast is for educational and informational purposes only and is not intended as medical advice. Please consult a licensed healthcare provider for guidance related to your specific situation. We'll see you next week.